Welcome back to Health Digest. We are discussing TB and the impact, the socio-economic consequences of TB in the country. And in studio, we have Josephat Asande, who's a former TB patient. We have Elizabeth Mweni, who's the Nairobi County TB coordinator. And last but not least, we have Dr. Herman Weyenga from the Centers for Disease Control, who's a public health specialist in the area of HIV and TB. And just before we continue with this second part of the discussion, I'd like you to watch just a sneak peek or a section of what we found out as we prepared for this show on what is happening in the Kenya Prison Service, and specifically the Nairobi Remand Prison, on how they are managing their TB and the risk for TB in the prison service. Let's take a look and then we'll come back and continue this discussion.
Na nikakuja nikakaa kule Broko J. Na nikiwa huko ndipo nikagojeka. Nikaletwa kwa hii hospitali ya hapa. Nikaanza kushughulikiwa.
We have a prisoner's health record, which is known in short term as PF10. This we do administer after asking the suspect their medical condition. We take them through, and this document entails screening them in terms of their TB. If, for example, they are coughing, for how long have they coughed? Their body, in terms of weight, have they lost weight for the past few days? In terms of if they are feeling fever at night, are they sweating extremely? And maybe, if initially they had attended clinics while they were outside the prison, in terms of if they were taking medication in TB or their HIV status.
What is it about the prison setup that makes you actively screen and look for TB?
You know, these people, before they are brought to us, they pass through the judicial system. When they go to the police station, you'll find that they are mixed into the cells together. So you might find that those people who have TB symptoms and those people who do not have TB symptoms. So when they go to court and they are brought to us, there are high chances that they might come, if one person had TB, maybe had infected maybe some people in the cell.
Walinishika wakanipeleka Kenyatta, nikapimwa, ugonjwa ikakosekana. Miezi mbili nikitafutwa ugonjwa, haikupatikana. Nilikuwa mbaya, singeweza kusaidia mtu, lakini wakati nilikuwa mgonjwa nilisaidiwa sana na watu wengine. Kwa hivyo wakati nilipona, niliona hata mimi nijitolee, niwe nikisaidia watu.
Mnatibiwa aje ama mnaendelea kukaa na wenzenu ama mnaeka?
Hapana, tukisha tu mpeleka pale, asemekane sasa ameanza kupimwa. Anatolewa kwa wale watu wengine, analetwa kwa hizi broko, nasikia zinaitwa broko C. Anakaa hapo. Kisha julikana ako na ugonjwa, analetwa hapa C5. Akikaa hapo kama miezi mbili, anapelekwa C4. Sasa hapo akipona, anapelekwa pale tena, anapimwa tena. Anaonekana hana ugonjwa, sasa anareleaswa, anarudi kwa watu wale wengine.
In 2013, we had 88. In 2014, we had 63 cases. In 2015, we had 43. 2016, we had 42. And last year, we had 27 cases.
So what happened between 2013 and 2014? Because now the numbers have really come down. What major thing happened that now they've been coming down?
In 2013 and 2014, we started. We had already the the screening mechanism at least was improved.
So that is the Kenya Prison Service, specifically the Nairobi Remand Prison at Industry Area, and what they're doing to manage and contain their TB cases in the prison. And they have been able to reduce the number of TB incidences, and even in the transfers, they've been able to reduce those numbers, as we have seen in the story. And back to our panelists, I'd like to ask, and specifically to Dr. Herman Weyenga, there are vulnerable groups in society that are more predisposed or more at risk for TB, and the prison service or the prison sector is one of those. Apart from the prison, are there other groups that are more vulnerable to TB?
Yeah, of course we have populations like slum dwellers, people who live in houses where ventilation is not very good, and again where the level of poverty is high. We also have people who live the nomadic populations, people who move from one place to another, having limited access to healthcare, and their housing is also in a situation where it promotes TB transmission. We have street dwellers, people who live on the street and they don't have good housing. There's poverty, poor nutrition, and other population. Mm-hmm. Of course, children are, as Mweni talked about, they are also a vulnerable population.
Okay. And specifically for Mweni, you are coordinating issues of TB, leprosy, and lung disease in Nairobi County. Are there specific areas where you find that the prevalence and the incidence of TB is marginally higher than in other areas of Nairobi?
Yes. I'll talk about the slums, as Dr. Haman has said. In the slum area, due to high population and overcrowding, we are having more cases in those areas. And also I want to add about a vulnerable group that we have is the street families. We are really getting them, especially the last 2 years, most of them are coming down with TB. And it's something that we identified, and we were able to do a lot of screening in the street families. We were able to get at least the key people, because they usually have their dens. So we are able to train the key person in each den. Once they identify someone who is coughing, they are able to refer. The problem we have, they are mobile population. Today they are here, tomorrow they move on. So when you got the key people, we are able at least to ensure that we are able to control these people. Then healthcare workers, we are having a lot of healthcare workers in Nairobi. I thought is one of the major vulnerable group that we have. They are coming down with TB. Currently we have 2 healthcare workers who are having the drug-resistant TB and they are being treated for. So that is one area that I thought healthcare workers are a vulnerable group. And we are trying to ensure that we screen every 6 months among ourselves to ensure that no one misses out to be screened for TB. Then another population that is coming out that I thought is a vulnerable group is drug users, IV drug users. They are coming down also with TB, and those who are those who drink a lot of alcohol. It's something that we are doing for this year. We are really screening the illegal dens down in the slums, because we thought the population of those who are drinking, they are coming down with TB. Because of the area is there's a lot of overcrowding. So it's something that we are doing. We are trying to get the bar owners in those areas to be our ambassadors, and we are going to do a lot of screening on those areas. It's something that we are going to give report, because we did it last week.
Okay.
Yeah.
And you're talking about actually going out and screening.
Yes.
Is this the active case finding that the two of you have been talking about? And
Yes.
is that the only aspect of actively looking for TB and screening for TB that happens?
No, not even that. Even at the facility level, we are doing active case finding in all the departments. We are not doing a lot of this in the outpatient department, but currently we have even trained our clinicians. Once a patient, we have a lot of respiratory tract infection that is coming down. In fact, it's the highest morbidity in Nairobi. So we ensure that we train them so that they are able to screen those patients who come with respiratory infection, that they are screened for TB. We have seen the children malnutrition is very high. That is one of the key signs for TB among the children. So we are even talked to our nutritionists in the child department, so that if they get these children, while they are giving them nutritional counseling and therapy, they are able to send them for screening for TB. Mm-hmm. So it's all inclusive. At the facility level, we are also doing active case finding, both in the child department and in the other, even the specialist clinic, diabetic, pediatric clinic and the wards, we are doing a lot of screening so that we don't miss these cases. Back to the community, when we get a client from an area, or many patients are coming from one particular area, we do targeted screening in that area so that we compound the area to ensure we get enough cases. One thing that has really come out, we are having young men and ladies coming down with TB. Those who are going for schools, those who are in colleges, they are coming down with TB, and this is an area that we have planned to ensure that we train teachers on how to to look for TB among the children that attend the schools, because currently, I'll talk of high school. We have 3 children in high school who have the resistant pattern of TB. Young ones are also coming out with in primary school having TB. Some teachers don't know how to handle, and they end up segregating these pupils from schools. So we want to do a lot of training to ensure that the teachers have the knowledge to educate even others. We have done a lot of school health education to give them knowledge on the signs of TB, and they are able to refer.
Okay, and I'll come back to just tell us what the public and the teachers that you've mentioned, what they should do once they suspect or they have somebody they have to manage who has TB. But before that, I want to come to Josephat. Sandy, from your experience having gone through TB treatment for the time that you went through treatment, did you learn anything? And are you now like a TB champion, like what we have in the prison service? Or has it changed your life in any way?
Yes, but before I come to your question, you asked me earlier on that which kind of side effects that come along with when taking TB treatment. So I would like to mention 2 or 3. So one of the side effects is that when taking TB treatment, you may find that you cannot see properly. Pia kuna ile kuvimba miguu.
So you had the swelling.
Yeah, yes, yeah. And the last but not least, kuna ile you find that itching of the skin, more especially when at the joints. Yeah.
Okay. How did you manage these side effects? I mean, when you wake up and you cannot see properly, what goes through your mind, and how do you handle that situation?
So I was told that when the kind of side effects comes, I must go to hospital directly. Yeah.
So what did they do when you went to the hospital? Were you assisted in any way, or what happened when you had all these side effects and you presented at the hospital?
Yes, I was assisted. Like as Moin said, there is this medicine called paradoxin. Yes, those are the drugs that actually finishes off the side effects. Yeah.
Okay.
Yes.
So now, has the experience of having been diagnosed and treated with TB changed your life in any way, such that probably, I don't know, are you more keen when it comes to issues of TB?
Yes. For example, right now, I help people around the community, even teaching them on how to prevent TB. So, for example, I find some time, I go to health facility and educate people on signs and symptoms of TB, how to prevent. Yeah.
Okay. All right. And he's talking about helping people in identifying signs and symptoms of TB and how to treat TB. But my question is very specific to the two of you, because now you're at a different level. In the school, like you have said, how should teachers handle students who are going through months and months of TB treatment? Let me start with Herman.
Yeah, taking treatment for a very long period of time is something that requires support, and I'm sure many of us have had trouble completing 7 days course of
3 days of antibiotics is a problem.
So we really need someone to support a patient, to be properly supported. One, to be accepted and people get to recognize that this is a common disease that can get anyone, and get someone to remind them to take their medicine. We have side effects of the anti-TB drugs. It's not something that can cause someone to totally stop treatment, but we need to recognize and anticipate them and let the patient know that these are side effects that are expected during the TB treatment. For isoniazid-related side effects, we give them vitamin B6 because isoniazid reduces the level of vitamin B6, causing people to feel burning sensation, pins and needle sensation.
The ones that when you were talking about.
To us, yes. And we have that. We prefer sometimes to get a treatment supporter identified and tagged to each patient who will be reminding the patient that it is time to take your medicine, and if possible, to be there to help them get water, swallow their drugs, and just ensure that we have the patient swallowing drugs. Because sometimes we put so much pressure on the patient to take their drugs, and sometimes people feel like this is not my role, but it is somebody's role. I'm being forced to take this. What we have in the HIV world, in HIV programming, we really train the client and about the importance of taking the medicine to the extent that the patient owns the treatment, and they are so empowered to the extent that they're able to take their treatment without a lot of supervision. And I think this has worked given the results that we are seeing.
Okay.
Concerning, probably the other thing is nutrition. If someone doesn't have food in their stomach, taking drugs can be quite burdensome. And we also encourage that this patient gets nutritional support. And I think in some of our programs, we are able to provide nutritional support to patients who are not well nourished to ensure that they have fed well and they're able to take their medicine. This improves the treatment outcomes.
Okay. And Tumwe, he has explained what the patient at that individual level, what people should do. But in case a member of the public suspects that in a certain household or in a certain community, there is a likelihood that somebody has TB, what should somebody do?
Referral. One thing I want to say, we usually have community volunteers, and community volunteers are usually attached to household. So if this person, they are aware and they know who is the community volunteer of that region, they are able to tell the community volunteers. The community volunteer will visit the home and be able to give the health education and do referrals. If these people are not willing to come to a facility, the volunteer can always maybe pick samples from there and bring it to the facility and give feedback of the outcome. So I think it's everybody's responsibility to give knowledge about TB, to ensure that the referrals is done, and which will ensure that we get the patient as early as possible. What you are getting this patient, you are getting them at late stages. I'll talk about our Nairobi patient. Most of them, they are casual laborers, most of them. So, you know, if you leave work today, there's no money for you. So you work until now, you are at the late stages of TB. That's why you come to the hospital. We want to get these cases as early as possible so that we also reduce the spreading of TB in the communities. So what I'll talk about, we have community volunteers who are attached to household. If these people are able to know their community volunteers, they get in touch with them so that they are able to do the referral. If it's somebody they can talk to, they can go to the household and tell them to come to the facility, which will be able to assist them.
Okay.
Yeah.
Thank you. Now, Josephat, when you are talking to people about TB, ways of preventing or managing TB, how is the acceptance of this information like? Are people receptive, or do they say we already know and say there's nothing new you're telling us? How is the public reaction to this information when you are engaging with them at the community level?
Actually, they accept it because most of the people, they don't know much about TB, you see. So I think they come near to hear what is TB and how to prevent it, and even to treatment, yes.
And in the event that you have somebody you're suspecting that has TB and you refer them, do they follow through? Do they go through the referral process and get treatment, or do they fall out of that referral process in the process?
Actually, if I refer a patient, I'm the one who is supposed to call back when the results is out. If it's a positive case, I call the patient, comes to the facility, and then I present the patient to the TB nurse for TB treatment initiation. Yeah. Yes.
Okay. Do such initiatives of having community volunteers or community health workers, if I may call them that, do this initiative translate to positive results in terms of active case finding, and are we seeing any improvement statistically?
Yes, yes. I want to just echo what our community volunteers are doing. Their contribution is really great. because of the referrals you are getting from the community to our facilities. I'll talk about the 2 years that we had TB cases in Nairobi, and there is much increase from 2016 compared to what we had in 2017. 2016, we had around 12,400 TB cases, and there was an increase to 12,800 last year. So we had at least 400 cases that came out, and this is just a whole everyone responsibility, both the community and the facility level doing active case finding, the community doing a lot of referral because we have taught them a lot about TB and what they expect so that they are able to refer. So a lot has been done, and we are seeing the cases coming out, although we are yet to read the 40% of the missing cases, but we are there. We have seen the increase so far.
Somebody may wonder that you're positively acknowledging an increase from 12,400 to 12,800.
Yes.
Why is it significant that we see this increase in the numbers?
Okay. I don't know if Harmony talk about this.
I think from Nairobi is a very important contributor to the number of TB cases we see, and every person who has TB has the capacity to pass this to 10 people by the time we are identifying them. So finding one TB case is very important. An additional case is very important. But if you look at the national numbers, the previous year compared to the 2016 and 17, we had an increase of all 12%, over 10,000 TB cases as an increment, which was as a result of the
initial... This is countrywide?
Countrywide.
Okay.
So if you look at the number of people who could potentially have gotten TB had the 10,000 patients not been identified, it's a huge number. So we actually saved quite a number of people from TB. But looking at what we did and looking at the contribution of many other players, going back to the prisons, we saw that we have TB champions within each ward, who every night monitor who was coughing a lot last night, and they will refer this person to the clinic. So we can see that there's also leadership at the level of the inmates themselves. They have taken it up, and they are able to identify TB cases. In Nairobi, again, we have a PEPFAR-supported project through CDC called Eastern Deanery Project. We have people who move to the community, and what they do when they come and engage members of the community, they first screen for TB, and then they offer other services. And if someone is found to have TB symptoms, the community health worker escorts this person to the facility where the sample is taken, and they get the best diagnostic tool that we have, like the gene expert test. So we have seen an increase in number just because of engaging the community work players. Now, looking at the other bigger project, the Global Fund supported active TB case finding in pilots in 13 counties in the country, but we also had other players who took it up. Like, for example, in Kenya, in PEPFAR-supported projects, we test around 13 million people for HIV, but this is only a portion of people who are seen by the HIV testing counselors. We see about 20 million other people who are evaluated for the possibility of being tested for HIV. But now what we are doing, PEPFAR together with the government of Kenya and other players, we want to have all these counselors screen for TB before they even ask you when you are last tested for HIV and see whether you are retested. In some of the areas like Murang'a County, Homa Bay, Siaya County, engagement of those has increased the number of TB cases we have identified between 2016 and 2017 quite significantly. So what the government of Kenya, the Ministry of Health, the TB program, and other players, partners, Global Fund and PEPFAR, CDC is doing, we want to have a massive rollout of active TB case finding in Kenya, so that when you come to the hospital, you will be asked, what is your name? My name is Herman. Are you coughing? Have you lost weight? Do you sweat? And those are 4 simple questions
like
that will help us.
Like the screening tool that the Kenya Prison Services are using to screen their inmates, to actively screen and look for potential new inmates or inmates with TB. Yes. Now, I want to move away from that and address the multi-drug resistant TB, and we at times have the extreme drug resistant TB. And when you mentioned that you have 2 healthcare workers in the county with multi-drug resistant TB, why should we be concerned, or why should we take a keen interest on multi-drug resistant TB?
Okay, these are severe forms of TB, and they have resisted the normal drugs that we use for 6 months. So one thing with the multi-drug resistant, what we call MDR, we also have other resistant patterns. They take longer period of treatment, and a patient will be injected for so long. So this is a process. How long
is this so long? It's okay. Good just to know exactly what we are doing.
We have the new shorter term regimen that was introduced last year, whereby now the treatment goes up to 9 months. Then a patient gets injection for around between 4 to 6 months. Yeah, depending on the culture result, if the patient has converted to be negative. So basically that is, no, we use smears to look at that. If the smears are negative, then the patient can move to continuation phase. But before that, the treatment was so long, the patient was taking treatment for 20 months, yeah, despite the normal treatment of 6 months. So it is very important when you get this resistant, the patient counseling now need to be more done. The patient need to take this treatment to the facility because we do strictly dots. They come every day to the facility. Sorry, direct observation therapy.
Thank you.
Yeah. So they usually come to the facility to take treatment on a daily basis. So it's a bit cumbersome. It takes a lot of time of the patient, and it's something that also we need to be concerned, because this resistant pattern can be also spread to the community, and we can have more patients who have resistant pattern. Like in Nairobi, currently we have 98 clients who are on drug-resistant TB treatment.
Okay.
Yeah.
Herman, what is the cost of managing multi-drug resistant TB? Because apart from the time duration it takes on the patient, what is the cost implication of multi-drug resistant TB that we should be concerned and worried about?
I think the cost is quite high. Looking at the cost of drugs has come down, but when you look holistically at the cost, is this patient has to be coming to the hospital every day for injection, or get a nurse to go and inject them at the community. So we are talking about productivity losses. This person not going to work. We also have a lot of other things related to the pain that people go through while taking the treatment. Talking about infection prevention and control, we also have other tools that we have to use when dealing with a patient who has multi-drug resistant, using use of masks by both the patient and the health and the provider. So we have a very huge cost. I think a few years ago we are costing this at over 1 million shillings to treat one drug-resistant TB. But if you compare that with the patient who has drug-sensitive TB, we only have about 5,000 to 6,000 shillings on the drugs, and this patient continues doing their daily activities.
And
so the cost is quite.
For the duration of treatment or monthly?
Yes, for the duration of treatment. Okay. So what I would say about drug-resistant TB is the first opportunity we have to prevent TB. The best treatment opportunity we have is to treat the drug-sensitive TB. The first time you encounter TB, ensure that the treatment is done correctly.
All right. Thank you. I'd like to just have your final and closing comments on this, and I'll start with you, Josephat.
Yes.
What advice or what would you like to tell the public as your final comment?
Okay. What I could like to say is that people should don't have to wait for, like we used to say that you must go for 2 weeks so that you can go out and get tested. I think nowadays we test for any cough. So even if you started coughing yesterday, go to the health facility and get tested.
Thank you.
Yeah.
Mweni?
Mine is just straight. TB is preventable, treatable, and curable. People should not just sit down and suffer in silence. If they have been coughing for any duration, let them request for a TB test. It is free in the government facilities. They can have that test done and know their TB status immediately and get treatment.
Okay,
yeah.
Thank you very much. Last but not least,
Yeah, we are missing half of TB cases in the country. Not that these patients are hiding anywhere. They come to our health facilities. So each one of us, healthcare workers, players and partners who are supporting the government implement TB control programs, patients who are visiting the hospital, we have to ask those TB screening questions. If we do that, we'll identify majority of TB cases in the country, and we'll be able to reduce the people we are passing TB disease to significantly in this country. Okay. So let us look for TB. TB is among us, and there's no normal cough.
Okay. Thank you very much, ladies and gentlemen. This evening, we have been discussing TB, and in studio we have Josephat Asande, who is a former TB patient who was diagnosed and treated in 2015. We have Elizabeth Mweni, who is the Nairobi County TB, Leprosy and Lung Disease Coordinator, and last but not least, we have Dr. Herman Weyenga, who is from the Centers for Disease Prevention and Control and a public health specialist in the area of HIV and TB. And we have learned about TB, and we are specifically discussing pulmonary TB, or the TB that presents with cough. Obviously, we haven't looked at other presentations of TB in other parts of the body, but this is a discussion we will continue with.